Good afternoon, everyone, and welcome to the National Collaborating Center for Methods and Tools webinar series on the Contextualizing Guidelines Workbook. We thank all of you who are here with us this afternoon, and we will be just doing a short introduction to ask you a few questions to get a sense of who's joining us today. I will then be introducing our presenter, Dr. Elizabeth Alvarez, and then we will turn it over to Dr. Alvarez for her presentation, followed by a time period for questions, and I'll speak to that in a moment. My name is Jennifer Yost, and I am a knowledge broker at the National Collaborating Center for Methods and Tools, and also an assistant professor at McMaster University in the School of Nursing. Before we get started today, just a few housekeeping things to mention. You can use the Q&A to post comments and questions during the webinar. Please remember to send questions to all, not privately to host, but if you do happen to send them directly to the host, I will still get those. For any connection issues, you can see my colleague at Health Evidence has posted a message in the chat box regarding to any technical issues that you might experience. We recommend using a wired internet connection, and we've also posted that WebEx 24/7 helpline in the chat as well. So just to let you know up front, after today, the PowerPoint presentation in both English and French, as well as the English audio recording, will be made available on our SlideShare and YouTube channels. And those direct links have been posted in the chat box. So we have a first polling question today. As I mentioned, we're going to try and get a sense of everyone who is joining with us. So we'd just like to know if you're joining just yourself or in a group, a small group, or a larger group. So as I see the group start to answer today, it seems that the majority of people are joining just themselves, and we have some groups of 2 to 3 and some groups of 4 to 5. So thank you to all that are responding. Very much appreciate that we're getting a great sense of who's joining us today. So as we move along, not exactly sure what happened there. I apologize for that. So again, this is our webinar series called the Spotlights on Methods and Tools, which the National Collaborating Center for Methods and Tools has been undertaking for a few years now. And this is our 23rd episode within the Spotlight on Methods and Tools. And as I've already introduced you, and as many of you know, joining in today, we'll be talking about the Contextualizing Guidelines Workbook. For those of you who would like to access the summary statement from the National Collaborating Center for Methods and Tools, we will post that link directly into the chat box for you. It can also be found on the registration page from the WebEx page. So another polling question for all of you, where are you joining from? Are you joining from within Canada? It'd be great if you could tell us what province or territory, or outside of Canada. And thank you to those of you who are responding. We have some participants from British Columbia, Alberta, the majority from Ontario, Quebec, New Brunswick, Nova Scotia. We have a really great sense of where everyone's joining from today. And we have a few people joining from outside of Canada, so this is really, really wonderful to see. Thank you all for your responses to our polling question, and it may remain open for a few moments as we move on. So for those of you who may not be familiar with the National Collaborating Center for Methods and Tools, we are one of 6 centers funded by the Public Health Agency of Canada, while 4 of the NCCs, or the National Collaborating Centers, support the use of research evidence in specific public health content areas. NCCMT and NCCM Healthy Public Policy work across content areas. And our focus here at NCCMT is to improve the access to and use of methods and tools that support moving research evidence into decisions relating to public health practice, programs, and policy. And we do have a variety of products and services available to support public health practitioners and others that may be interested in moving research evidence into practice. And our registry of methods and tools, which is are the features for our Spotlight webinars. So these Spotlight webinars, like today, feature summary statements of relevant methods and tools to help public health practitioners through evidence-informed decision-making. So again, still trying to give us a better sense of who's joining us today. If you could please tell us what sector that you are from. Are you a public health practitioner, other? Do you work in education, research, municipality, policy analyst, or of course other? So as I look at the polling results come through, and thank you to everyone who is responding, the majority of people are public health practitioners, work in research. We do have some people that are health practitioners working in education, are within the ministry and the municipality. So we have a great sense of people that are joining us here today. So thank you to all of you who have provided responses. So it's my pleasure today to introduce Dr. Elizabeth Alvarez. And Elizabeth is a licensed physician in both Canada and the United States, and was participating in the Healthy Policy PhD program at McMaster University. She completed her medical degree in family medicine residency at the University of Toledo in Ohio, and earned a master's degree in public health through Northwest Ohio Consortium of Public Health. She has worked in multiple healthcare settings in Canada, the U.S., and Honduras, including as the Associate Medical Officer of Health in Thunder Bay. Her PhD and research work revolves around knowledge translation from evidence to healthcare policy in low and middle income countries, and to support the local contextualization of global health systems guidance. So thank you today to Elizabeth for being here, and I am going to pass the presentation over to her and let her take it from there. As I mentioned, we will have a question and answer period at the end of Dr. Alvarez's presentation. So please, during the webinar, as well as at the end when we open it up, please provide questions in the chat or the Q&A as you go along. So over to you, Elizabeth.
Thank you so much, Jenny. And thank you, everybody, for joining today. I'd also like to thank McMaster University for supporting my research, and the International Development Research Center, as well as the Government of Canada through its Vanguard Canada Graduate Scholarships for funding my research. And of course, my supervisor, John Lavis at McMaster, the World Health Organization, for helping with this work, and also the NCCMT for sponsoring this webinar today. So thank you to all. Let's see if I can move the slides along. There we go. All right, so Jenny already explained a bit about knowledge translation. I wanted to put this in here. Most of you are familiar with this already, but for those who are not, there are many terms that are used, so knowledge transfer, exchange, brokering, etc. But basically, it's a process where we're trying to use research evidence and use it at the applied level, whether it's for practice or for policy. So that is really the basis of knowledge translation. So the background is that right now, many of our public health systems around the world are fragmented and they're overburdened, especially in low and middle income countries, but also in high income countries when we think about a public health system and how they work. The problem with that is that effective public health interventions, things that we know that work, go unused or are underutilized because there's no system to deliver these interventions. So there has been global evidence-based guidance that has been developed to strengthen public health systems. So this is the work, for example, of the World Health Organization and other international bodies that are trying to use research evidence to develop guidance recommendations. So whether we call them guidelines, which we typically think of in the clinical or health professional world, we call health systems guidance when we're talking about changes that affect the system. But the problem is that this guidance needs to be contextualized or adapted to specific settings. So we need to combine the global guidance with national or local evidence, as well as health system and political system assessments. There's been clear direction from the countries that they need to have more support in implementing these recommendations. And we know this because countries have been asking WHO for this support. Also at the International Forum on Evidence-Informed Health Policymaking in Low and Middle Income Countries in 2012, this was a clear theme. Many countries have started developing a culture of using research evidence to develop policy. But the questions that they're left with are these gaps in how do we take recommendations and implement them in our settings. So we developed a systematic, transparent, and user-friendly tool, a workbook, to help develop national or subnational policy recommendations or policy decisions depending on the jurisdiction. This workbook meshes global guidance and national or local evidence, and it also includes a broader health system and political system look. In 2012, the World Health Organization was developing a specific guidance document on optimizing health worker roles to improve access to key interventions to improve maternal and newborn health. And so they realized that the users would be policymakers, researchers, and other stakeholders. And so they wanted a tool to help the users contextualize their recommendations. And this is how this workbook came to be. The link for the workbook, it will be posted on the NCCMT website, but it's also posted at that link there. It's free to use, it's free to download and to use, so it is available to anyone who's interested.
Great, thank you, Elizabeth. And we would just like to get a sense of how familiar are you already with the Contextualizing Guidelines Workbook. And as people are responding, a few people have heard of the workbook. The majority of people are not familiar with the workbook. So thank you to all of those who are continuing to submit responses. We do actually have one participant who has actually used the workbook. So perhaps we might call on that participant later on in the Q&A or chat to get a better sense of their experience with using it. But overall, the group is not familiar. Some have heard of the workbook, and one participant has used the workbook. So back to you, Elizabeth.
Great, thank you so much. And I did expect that most people would not be very familiar with the workbook. It has not gotten a lot of press, I guess, and we can talk about that as well later on. All right, so the workbook follows the Health Systems Guidance Contextualization Framework. The framework was developed for the workbook. So I'm going to go into each of these steps a bit more, but just to give the overall picture, there are 8 steps. First, we clarify the problem, we frame the options, and we identify implementation considerations. For those of you who are familiar with developing evidence briefs, which have been around longer and have been used in quite a few settings in both low and middle income countries as well as high income countries, those are the steps that you would be familiar with. They are the most commonly found as part of the evidence brief development, also the support tools for using research evidence in policy decision making, as well as the SURE guides. These follow those first 3 steps. This adds that we consider the broader health system context as well as the broader political system context. And then we refine the statement of the problem, options, and implementation considerations in light of what has been learned of the health system and political system factors. Then we anticipate monitoring and evaluation needs, and we make policy recommendations or decisions. Now, I'm going to start at step 8. It's a very iterative process when we do this. The first thing that needs to be done, and in the revised version of the workbook, this will be most likely added in. But the first step is really to identify the venue. So when you're determining, you say, I'm trying to use these recommendations or this guidance document, you have to determine at what level you're trying to implement them. So whether it's at a clinic or health unit or provincial level or at the national level. It's really important because there will be different processes for policy making at each one of those levels. The research that's available to answer questions will be different at those levels. So you start out identifying the venue. That also lets you know who your target audience is. So that's a very important first step. And then we go through the rest of them. So first we clarify the problem. So this is a step that I find frustrating in a way when I have talked about this work or done hands-on work with people at the country level. The feel or the sense that I get from people is that if they have a guidance document that is around, for example, optimizing health worker roles, people want to jump in and just figure out what they need to do with those recommendations. What I find is that it's really important to take a step back to really clarify what is the problem in your setting and also what contributes to the problem in a specific setting. Because a lot of times we may actually be making the problem worse if we don't take the step back. So we can ask, is it a risk factor, disease, or condition? Is it the program, services, or drugs that are currently being used to address the risk factor, disease, or condition? Is it the current health system arrangements, which could include the delivery, financial, or governance arrangements? So for example, the guidance document that I worked with that this was developed for, it might be a matter of saying, well, we know we don't have enough doctors and nurses and midwives. So we're saying that we might have nurses and they can provide certain interventions. So we might say, well, the problem is that we don't have enough nurses. So if we go in with that assumption straight up, we might say the solution is we need to train more nurses. But it could be that even if we trained a nurse for every single person in the population, which would never happen, but let's say it could, it might be that people can't afford the fee-for-service that goes along with that service. So it wouldn't matter how many trained nurses you might have, it's a financial arrangement that's really underlying the problem, in addition to or perhaps even more of a problem. So if we put our money in a resource-tight setting into training nurses, let's say as an example, we might actually be drawing away from what the problem is, which could be the user fees. So we might need to change the financing system. This is why it's important to take this step and really go through what the problem currently is. It could also be the current degree of implementation of an agreed upon course of action. So if you've already created a policy and tried to implement it, but it's not being implemented as it should have been, you may not need to develop new policy. It might just be a matter of identifying the barriers to implementing the current policy that you have. So this is really that first step. Then you ask, how did the problem come to attention? So depending on whether it was, the way a program is running and you have indicators versus it's the third helicopter that crashed within a certain amount of time, how the problem comes to attention might put more emphasis on doing something about it now versus other priorities. What indicators and comparisons can be used to establish the magnitude of the problem? So, for example, if you're trying to say that there's a problem with maternal mortality in your jurisdiction, if you can say, well, we have a rate of, 10 women that die during childbirth out of 1,000, but our neighboring country or jurisdiction, province, theirs is 1 out of 1,000, you can start saying, well, maybe there's something we should be able to do about it, because they're not just, numbers, they're comparisons. And so people take that as, then there is a problem we can deal with. So again, this will help you say what the extent of the problem is. Now, number 5, how can the problem be framed or described in a way that motivate different groups? For those of you who are more quantitative, which public health workers tend to be, this might seem very wishy-washy, and I understand that. But how you frame the problem can have a huge impact on how you deal with it. So I'm going to give the example of guns in the U.S. You all know about this problem. We can say that the problem is that people are dying of gunshot wounds. So that is the problem. Now, what's causing the problem? For many people, the framing of the problem is that we don't have enough background checks. We don't have enough restrictions. There are too many guns, and so we need to therefore restrict the number of guns that are out there. We need to implement better methods for restricting who has access, more background checks, and so on. I have heard the Vice President of the NRA, the National Rifle Association, frame the problem as there are not enough guns. If every school had an armed guard, if every person carried a gun, they could protect themselves against others who have guns. So no matter how you see that, the way you frame the problem will change not only who is motivated to act towards it, but it will also change your policy solutions to deal with the problem. And in this case, they're opposite of each other. So it has a huge impact on what's actually done about the problem. So then we frame the options. Has an appropriate set of options been identified to address the problem? So we look at benefits, harms, and local costs of each option. And these can vary significantly. If we're looking, for example, at restaurant inspections in rural areas versus an urban area, in rural areas, we're going to have to consider the cost of travel, which may not be as substantial in urban areas. So it might be the same intervention, inspections, but the costs of carrying them out are going to vary significantly depending on the setting. You might also look at adaptations that might be made to any option and how that might affect the benefits, harms, and costs. Then you also want to look at stakeholders' views and experiences, which might influence the acceptability of each option. And again, we don't tend to look at acceptability as much in the quantitative world, but this can be very important. So one example is the use of lay health workers in different settings, especially in low middle income countries. If we look at the literature, it says that for some settings, people are very happy to have lay health workers provide the services because they understand the culture and the resources that are available and so on and so forth. But the flip side of that might be that if you're dealing with a sensitive topic such as sexual health or maternal health, these are people that live in the community perhaps, and so people may not feel comfortable disclosing information to people within that community. So you really do need to understand if people are going to accept this policy option, because it might create a barrier if you're trying to implement it. Then we identify implementation considerations. So we look at potential barriers to the implementation of each one of the options. We also look at strategies to overcome these barriers. And these strategies can be at the healthcare recipient or citizen level, the healthcare professional level, organizational, or system. And we try to identify those as early as we can as we go through the process. Then we consider the broader health system context. So what is the health system? The way we typically define the health system is broken down into delivery arrangements. So for example, who is providing the care, where is the care being provided, and so on. Also financial arrangements. How are healthcare providers being remunerated? Is it how are the fees? Is it a fee for service? Is it publicly funded? And then governance arrangements. Who has authority for decision making within the system? And I'll give more examples of that at the end. But we work through each one of these, and then we look at the political system. So we look at political institutions. This might be, for example, is it a centralized system, such as in England, where the policy is going to affect the whole country, or it might be a federalist system, such as the U.S. and Canada. And so where does the policy need to change? Is it at the federal level, or is it at the state or provincial level? So identifying that venue, but also then seeing what policies are in place within that jurisdiction. You have to look at prior policies and laws. So one example of this is that I was working in Peru, and the ministry's goal was to decrease adolescent pregnancies. So we looked at one remote region of Peru, and so we were working through, is it, midwives, nurses, who can provide contraception to the population there. However, there is a law in Peru that prohibits any providers from providing contraception to adolescents. So even if you're recommending that midwives, for example, could provide contraceptives, it's actually going against the laws of the country. So you can't make that as a recommendation unless you give a caveat that says there is a law in place that prohibits this, and so therefore other changes must be made before saying that midwives or auxiliary nurses can provide the contraceptives. Then you also look at what politically active groups might have an interest. So this would be, which groups face costs or benefits from the policy option, and therefore this group might mobilize for or against each option. So one example is if you're saying that auxiliary nurses can provide one of the interventions, but the nursing group might say, well, we don't feel comfortable because we have to supervise the auxiliary nurses doing it, and we're not sure that they have the training within our jurisdiction. So they might mobilize against instituting this option. And you don't want to wait until the policy is in the books, because then you're going to face these barriers. So it's a waste for everybody to have gotten to that point without their input into the process, or at least to consider whether they might be for or against these, or how to work with them in implementation. We also look at the beliefs and values of not only the government, but also the public. And so we might look at polls, we might look at the national mood, but we also have to consider the beliefs and values of the government officials, which may be different from the public. And there's also external factors, and these might push the issue forward or draw attention away from the option. So if you have a natural disaster occurring, chances are maternal health is not going to be worked on at that time, and it may need to wait. It might also be that a high-profile person, be it a celebrity or someone who is a politician, might have had complications during labor, and all of a sudden this becomes a hot issue. So this might change what is the priority on the government's agenda. Sorry, I'm trying to advance the slide. There we go. So step 6 is to refine the statement of the problem, options, and implementation considerations in light of health system and political system factors. Now this is written into the workbook as a separate step. In reality, during, through the use of the workbook, you really are doing this on a continual basis. So if you come up with a barrier that is significant, for example, that law in Peru, you do go back and you maybe look at the options or how you could shape them differently. Or you might just have to say, at this time, this is not an option that's going to move forward. So you are doing that on an iterative basis. But this is in the workbook just as a pause to think about making sure everything aligns that you have done so far. We anticipate monitoring and evaluation needs. So we ask the question, is monitoring necessary? We tend to work, all of us tend to work in a very evaluative mindset. And so our answer is usually yes, we need to monitor and evaluate. But when we're short on resources, and even given our climate here in Ontario right now in public health, we need to consider the resources. And so we might say, is there already a system in place, or would we need to set up a new system? What are the costs of establishing a new system? And if we do have any particular findings for or against this program or intervention, what are we going to do with those findings? Would we be willing to actually stop a program if we found that it was not effective? Would we be willing to change the program? And so this needs to be kind of a thought out, because it does use a lot of resources if you're going to do a good evaluation. Once you've decided that you should, then you ask what should be measured, and then should an impact evaluation be conducted and how it should be done. Now these questions, many of these questions come from the support tools, and that's a series of articles that are written to help policymakers and those who support them in using evidence in policymaking. So there's more description of these within the support tools as well and in the workbook itself. And then step 8 is we make policy recommendations or decisions. So if applicable, depending on your jurisdiction and the topic, has the public been engaged in the policymaking process? This may not always be realistic, but it's certainly something that there's a lot of research into this right now, and a lot of discussion around public engagement and stakeholder engagement as well. So then, is there a policy brief being developed to gather all of this evidence into one document that very systematically sets out what the problem is, what are the options, and this implementation considerations? A policy dialogue then is it's a dialogue. It's between policymakers, researchers, stakeholders to come together, hopefully face-to-face, but they use the policy brief as a jump-off point to have a discussion, to discuss the framing of the problem and any implementation considerations and so on. This allows for there to be a fuller discussion about things that may not have been found through research, but also it helps engage those policymakers and stakeholders in the final decisions. They have more ownership around this. The McMaster Health Forum has done a lot of work around this, and I believe there are many other jurisdictions that have also used similar methods, if not called a policy dialogue. But that has been well studied both in high-income countries as well as low- and middle-income countries. So I know the workbook has been there. I am the one who has used the workbook, I guess, as I was answering the polling questions. So I want to talk a little bit about this process. I studied the process of using the workbook in Peru and Uganda in 2 different settings. So the findings that I will give you today on the evaluation of the workbook reflect 3 changes in the process. So when you're doing qualitative research, you have to be very clear about what changes you are making to the research process as you're doing it. So there are 3 changes in the process for the people who are used to developing an evidence brief in their normal processes, and then what we did in this study. So first, there was this workbook, which was specific to contextualizing the specific guidance that we're using. So this was unusual. The support tools and the SURE guides are both generic to topic and context. So this workbook was different because it provided examples that drew from the topic at hand. We also had the 2 authors, so myself and my supervisor, John Levis, from Canada, who provided support throughout the process in both Peru and Uganda. And they don't always have such support. And in addition, we worked through the guidance document for all the relevant recommendations. And from what I gathered from the participants in this study is that typically they define what their needs are, so they'll define a problem area, and then they research, and they'll use the guidance documents from WHO as one of the research inputs. But they don't necessarily work through every every recommendation that's provided in the document. So they use it more as a reference, but not necessarily as a document to work through systematically. And we very much did that in this process. So the advantages of using the workbook. The top one is a little bit highlighted there. Participants in both countries planned or have already used the workbook for other unrelated work. Both the people that I worked with in Peru and Uganda were already developing evidence briefs, so they were already familiar with the concepts of using evidence in policymaking, how to engage policymakers, and all these things. But they found that the workbook was useful to the point where they were going to be using it for other projects, for other work. The workbook, which was specific for contextualizing this guidance, made the process faster and easier when compared with their prior processes, according to the interviewees. The workbook was systematic, logical, and user-friendly. So it served as a tool for developing the evidence briefs, but it was also a checklist for evaluating the work. So the people who weren't directly working with the workbook, but were supervising the work, said that they were able to use the workbook as a checklist to make sure that we're covering all the different points. There was one concern that was raised by one interviewee, that because it's so systematic, it could limit people's thinking about the problem or how to address it. Now, this is going to be the case anytime you have a tool, and there was no particular area that was raised by this participant in terms of how to bypass that or how to change that. But with any tool, we have to be aware that we have to incorporate other things even if they may not be included in the tool. So that would be more of a generic statement for tools. The examples in the workbook was seen as helpful. There was some disagreement whether there should have been more examples. Everyone who I worked with felt that they had enough examples provided, but they were more concerned about people who weren't as familiar with the processes of evidence-informed decision-making, and also for areas that maybe had more limited data. I can tell you that in Uganda, there was a lot of information that was missing around maternal and newborn health. We were not able to find district-level evidence. That just wasn't gathered in the country. And they still felt that they had enough examples, but they were more concerned about other areas that may not have that data. Country experts were helpful for both content and methods, and this cannot be emphasized enough. The World Health Organization and other groups cannot do this work for the countries. They don't have the resources, and that's not their expertise. Their job is to work at that global level. So you do need people in the country who understand the health system, who understand what the roles of different health providers are. They understand the political system, the context, the processes around policymaking. So that cannot be emphasized enough. The outside support was helpful for building capacity and focusing attention on the work. So I helped do some of the background research. I also helped coordinate some of our meetings and so on. So that's for a place like Uganda where this was off the side of their desk, I was able to provide some of that, coordination of meetings and so on. The process of using the workbook helped identify gaps in knowledge and in practice, and it helped evaluate the optimized MNH guidance itself. As we were working through, we found that there were some pieces missing in the guidance document itself, or very much so in research areas. So we wanted to have some kind of mechanism where we could say, these are the gaps we're finding in the research evidence that could help in the policy-making process. It's also important to emphasize what this workbook and the guidance document cannot do, so expectations for this work. Again, this, WHO and the workbook cannot provide every scenario for every topic. So it would not be able to say, if you have this political system and this health system and this level of worker, you should do this and that. That's where the country experts are needed, because it's not, the expectation cannot be there that the workbook is going to answer all of those questions for every given setting. It also can't direct what the country should do to make the changes that are necessary to support the policy options. So in Peru, for example, the workbook would not be able to say, well, you should change the law so that you can now provide contraception to adolescents. That's not the role of WHO or of the workbook or of the guidance document. Those are things that happen within the country or at the district level. So just to set up expectations for the work. Challenges of using the workbook. The workbook is long and complex. If any of you have looked at it, you'll see that. There's a lot of questions. However, every interviewee, I asked them what parts could be left out, and they could not pinpoint any. In fact, they all said that every section was important. So we're still working on how to make it shorter. But this is tedious work. It is a lot of work. It's complex work. And so there are a lot of considerations to take into consideration when thinking about changing a public health system or a health system. And the more that the barriers are thought through, the idea is that it will be more likely to be implemented. The workbook had areas of redundancy and overlap, and this is the nature of the work as well. When you're defining the problem, you're going to, be trying to answer about some of the barriers. But then as you develop each option, you also have to determine barriers for that particular option. And the workbook had missing components. Again, this is probably part of the expectations. There was no glossary of medical terms, either in the guidance document or in the workbook. Most of the people I worked with were health professionals of some type. Some were not, but we did have discussions as a group. But for people who were not healthcare professionals, it would have been difficult to understand, why did we, for example, one issue that came up was when you're doing an external cephalic version, a healthcare professional who is trained in this area would know that, what are the potential complications of doing the procedure? What are the requirements for carrying out the procedure? Whereas somebody who would not have the health training would not have that sense. So this is why it's important to have a team of content experts as well as methods experts. And then advocacy was brought up, but it's not really clear whether advocacy should be part of the workbook or it's just part of the work that goes into developing policy and using evidence for developing policy. Costs are addressed in the workbook, but as several interviewees pointed out and is very clear, policymakers are very interested in costs. So there is this gap between researchers and evidence users and understanding the real costs in terms of the policy itself. So there are resources for finding costs, but again, when you're talking about a large scale, it is more difficult if you are working in this area to say, well, this is the exact cost. But that is something that needs to be thought about in terms of developing these policy options. What are the true costs involved? The other challenge is the language which is used in the workbook could be difficult for those who don't have training in health policy and systems, and also English terms may not be translated exactly into other languages. All the people who worked on this, whether they were Spanish speakers or in Uganda English speakers, did not feel that language was an issue for them. They were more concerned about people who didn't already have that knowledge. However, some of them said that the workbook helped explain the terms, so they didn't feel that that was an issue as well. So again, some variability in that. So the next steps for the workbook, I am working on revising the workbook based on the findings of this work of evaluating the process of using the workbook, and also from a critical interpretive synthesis of the literature that I did to better define contextualization and contextual factors that affect policy development and implementation. So that is in the works, and once that revised version is complete, that will be uploaded into the NCCMT website, I'm hoping. Other steps are that I will be looking to test the workbook for other topics and contexts. So the workbook itself, the questions, as you see, are very generic for content. But to be able to use the workbook and say it is helpful for these other topics and possibly using other examples will be important. The other issue is for any of you who are interested in using the workbook or who have are dealing or grappling with how to contextualize guidelines or guidance for changing systems, I have submitted to do a Learning Institute at the American Public Health Association conference in the fall in Denver, Colorado. If any of you are planning to attend the conference and would be interested in having a hands-on time, of course, with me to develop your topic, where we can look at types of evidence that you can use for your topic, and so on and so forth. Let the directors of APHA know that you have that interest. It will be a small group, no more than 25, but it is a competitive process. So if they see that people are interested in this, certainly let them know. So that is another opportunity as well. And for those of you who will not be going to APHA but are interested in using the workbook for your particular topic, definitely feel free to contact me. And Jenny, I'm not sure if, I think my email can be posted somewhere. But anyway, that is another possibility as well. And I would be interested in seeing how the workbook can be used within other settings and topics. So I think with that, these are my references for the presentation. The second reference, I'm going to give you just a couple more tables at the end of this presentation, the Lavis article. And I thank you very much, and I am happy to answer any questions. So table 1 here are the key features of a health system. And so this breaks down a bit more the governance, financial, and delivery arrangements, and provides some examples. And then these are the key features of a political system, so the institutions, interests, ideas, and external factors. And again, some examples there. And these are all from that article from Lavis et al. All right, so thank you very much. And, please feel free.
Great, thank you, Elizabeth, and thank you to everyone who have continued to stay on the presentation with us this afternoon. We are up to a total of 66 attendees with, as we mentioned before, people joining in groups. So, Elizabeth, we do have a few questions for you that have come in. So the first question is from Denise, and Denise would like to know, since I'm not familiar to this workbook and according to the challenges of its use, how and what will be the best way to address this?
Sorry, so the challenges of, what was specific? I didn't hear that.
No worries. So Denise commented that, she's not familiar with the workbook, and again, you shared some challenges with its use in practice. So she, I believe, and Denise, you can correct me if I'm wrong, was in the chat. So Elizabeth, do you have any suggestions on how and what would be the best way to address some of the challenges you mentioned?
Sure. So I think the biggest challenge is having someone dedicated to doing the work. That's first and foremost, because it is a process. It's not a, you can't sit down with the workbook and work through it in a day or two. If you're going to develop policy through this, you do need the content experts, and you do need the people who understand the policy processes. So if you have, I guess my answer is it depends on your context. If you have a process in place already for using evidence in policy making, this is going to be much easier to use if you're already familiar with evidence briefs and you have that set up. Basically, the workbook then would help develop that evidence brief. If you don't have the process in place already, that's a much bigger job. So in that case, it would be maybe looking at, places like the McMaster Health Forum that does this work, or an equivalent in your jurisdiction. So I'm not as familiar within Canada of the different points of where this is happening. In many low and middle income countries, they have EVIPNets, or they have evidence-based platforms. So these are groups of people within the country that are working with policymakers and researchers to bring research evidence into policymaking. So it depends on your jurisdiction and how well developed these processes are already. And if you have any specific questions to your jurisdiction, or you're interested in setting up more of these processes, that's a bigger discussion. But that's certainly something that we can discuss offline as well.
Thank you, Elizabeth. And you mentioned that we could share your email with the group. So I know that you have a McMaster email and a different email. Which one would you prefer us share with the group? And we can do that now, actually.
Sure, that'd be great. Let's use the McMaster email. That would be
great. Okay, thank you. So we'll share that with the group. Thank you so much for that. And Linda has a question. She would like to know, is there a blank template version of the workbook that someone could access, or do they need to build it from scratch?
So the one that is online through WHO, the link is in the presentation, and Jenny, maybe we can post that again. But you will also, Jenny will also be posting this on the, it will be on the NCCMT website as well, if I'm correct. So that is a blank template. It does have the examples with, the maternal and newborn health guidance. But if you take out those examples, the questions are generic to any topic. So that template is there, the workbook is there, so that you can, download it and use it.
Great, thank you, Elizabeth. And a question from Michael. He says, thank you for the great presentation. I am involved with adapting and adopting clinical practice guidelines. Can the workbook be used with implementation of guideline recommendations? And how do you ensure the evidence trail from the evidence you used within the same context of adapting or adopting recommendations from existing guidelines?
Yes, thank you, Michael. I have been very careful, because this was part of my PhD work. I have not wanted to kind of overstep what the purpose was, which was the guidance aspect of it. The way I see it, though, after having done my research, is, in fact, that for clinical guidelines, so clinical interventions, this is actually a very useful approach, because what I keep seeing in the literature is, we're not implementing guideline recommendations. We're not implementing guideline recommendations. So where is the problem? And a lot of times I think we forget that we might have a clinical guideline or an intervention or a program, and we try to implement it, but we don't have the system to support the implementation. And so when we look at the health system itself and how it can support the implementation of guideline recommendations, I think that's a huge missing piece. It's addressed in some forms, but not to the specific level of what I've presented here, which is more talked about outside of the guideline literature. It's addressed more in the health systems literature and policy literature. So there's been a gap, I think, between these two worlds. Sometimes if you're trying to implement guidelines at a higher level, so at a provincial or state or federal level, then we definitely need to be thinking about the political system. Especially if it requires changes in, for example, training, because a lot of times training is done through the ministries, and so you need either provincial or federal changes in training requirements, or you might need legislation changes at the different levels to support these interventions. So depending on the intervention and depending on the venue that you're trying to make the change at, yes, I do believe that this would be very helpful for those changes as well, and that could support some of that process, and especially to identify the barriers. So yes, I do believe it could be. I hope that answers your question.
Yeah, so Michael, let us know if you have any follow-up questions from Elizabeth's reply. And another question from Jen. She is wondering if you are familiar with the grade process. She would be curious to know about what overlaps you see between the grade process and the workbook, as well as your opinion on if you think the workbook is still useful when the grade process has been used to develop guidance.
Yes, great question. So the grade process is used more in evaluating the quality of evidence. So typically that's being used more when you're developing guidelines or guidance documents. Now, grade tends to be fairly quantitative, and so you're looking at it in terms of guideline development is very useful. The work that the WHO is doing will use grade frequently, or they have some other tools that are also being used as well to assess the research itself. However, when you're dealing with policy making, not all your evidence is going to come from peer-reviewed journals. So you do need to look at a very broad range of evidence. Some of it may not be considered, the highest quality because we're not looking necessarily at effectiveness. So when you're trying to decide whether policy changes should be made, you may have to go with some of the media reporting, some of the national mood, some of the polls, the ideology, the beliefs. So you're looking at a much broader type of evidence base than just peer-reviewed quantitative articles. So there is a place for grade, and that's usually within the guidance development. You can also use grade when you're looking for research evidence yourself in terms of these policy recommendations. But generally, for policy, you're looking at a much wider range of data, which could include, and by the way, the workbook does include what types of research you might, or evidence you might use to help answer some of these questions. But it might be administrative data, which you wouldn't have as a peer-reviewed article. You wouldn't have it as necessarily, a grade approach. So you'd be looking at, is it administrative data? Is it the functioning, program evaluation? Is it, systematic reviews? Those sorts of things. So grade does have its place, but I think this has to have a broader look, if that makes sense.
Thank you so much, Elizabeth. And we'll wait to see if anyone has any further questions. Michael did say back to you, thank you. You have question answered, so that's really great. And so we'll just proceed along. We have a few more slides before we do wrap up, but again, please feel free to continue to post questions in the Q&A or the chat section for us to ask of Dr. Alvarez. So your feedback is quite important to us. As you obviously see, this is one of a series of webinars within our webinar series. So we'll be posting a link, and we just ask you, if you do have time, to take a few moments to complete a short survey on our webinar today. So thank you very much. I'm not seeing any questions come in, so we will maybe just throw this polling question out while we wait to see if anyone has any additional questions or comments. So wondering what everyone's next steps are in terms of the Contextualizing Guidelines Workbook. And so as people are responding, and again, you can respond to as many different of the responses that you would like. So you don't have to just say that you'll do one. You can do multiple, and this will give us and Dr. Alvarez a great sense of how applicable I think the workbook is. And yeah, so it seems that most people will definitely access the workbook, which is great news, followed by a lot of people will read the summary available from the Collaborating Center, and a fair amount of people are also considering using the workbook and telling a colleague about the workbook. So thank you all for your responses. Again, I will just wait to see if anyone has any additional information or questions for Dr. Alvarez. Maybe, Elizabeth, if you don't mind, I'll just ask you a quick question while we wait to see if anyone has any more questions. So just wondering if you have a sense of how long it takes to get through the workbook, and perhaps based on that, can you do it in sections or any kind of practical information that you can offer?
I'm glad you asked that. I meant to address that before, too. The process itself really depends on the jurisdiction. I can say that in Uganda, barring the background work and so on, I was there for 2 weeks. So within 2 weeks, we had discussed the topic. We had discussed how we would go about doing the process and who would be involved. But we didn't actually, again, this was done off of the side of their desk. So they had many other things happening. So in the 2 weeks I was there, we were able to work through the workbook. We were able to meet with the working group. So it was a very concentrated time. I had done some of the background research before I got there and also during my time there. So it was very, very concentrated. Typically it would be a much longer process. In Peru, we started working on it. However, in Peru, the ministry makes the policy decisions, as opposed to in Uganda, we're making recommendations. Again, all depends on context. In Peru, because the ministry makes the policy decision, once they determine what the policy is, that's the policy for the country. And so they have a very different process that they go through. So we had started out with one topic. We had worked on that for some time. But then the minister, they had a huge turnover of key people in their ministries and all throughout the government levels. And their minister changed, and with that change, we had to change our topic. So, it just goes to show that the political context makes a huge difference. So we did change how, what we're looking at specifically. But I would say, so overall this work, if it's really, really concentrated, I would not recommend 2 weeks. I would recommend a longer process. And this also depends on who all is involved. And then, at least several months to really work through. If you have a working group, that's going to add some time because you have to find times for them to meet. So it really, again, depends on your setting and your jurisdiction and the scope of the problem that you're dealing with. And whether it's, a hot topic or you have to do more advocacy. So that's all going to determine how long all of this takes. In Peru, we have been doing the policy dialogues. It's an ongoing process. And there was a meeting set to basically to kind of do the final stages and develop this into policy. However, again, the district person changed, and so they had to reset the timing for meetings, and that person had to get up to date with all of their priorities that were happening in addition to this work. So that has delayed this process moving forward in Peru. In Uganda, we're still working on getting the policy dialogues going. And that's because, again, nobody was dedicated to this. There's no position for this work to be taken on by a person at the ministry. This is more of a group that does this work, and then they have contacts within the ministry. So we're still in a different process, part of the process there. So it depends on your setting and your processes, how long this could take. According to the interviewees, the process was faster because of the workbook. It helped them identify what types of information they needed, so they were able to gather that information more systematically, in a more systematic manner, and so they didn't have to go back and say, oh, I forgot to kind of ask this question, and then that changes everything again. So they felt that using the workbook was faster and easier than their usual processes. So yeah, I would say minimum, 2-3 months if you have a well-organized system. Otherwise, you might have to do more advocacy and, depending on who's involved, policymakers and so on, it's dependent on their timing as well.
Thanks so much, Elizabeth. And we do have another question from Ayrton, and I hope I said your name correctly. And they would like to know, is there any way to stimulate all stakeholders to be engaged in the process for implementation? So maybe any key thoughts or, experiences you have about stimulating all stakeholders to be engaged in the process for implementation?
Yeah, that's a great question. The McMaster Health Forum has done a lot of work around stakeholder engagement, so they would be a great source for this. I'm going to say again, as I say in all my lectures, it all depends. It depends on the topic, and on the context. If it's an issue that affects people but not directly, so they might face diffuse costs or benefits, people are not as likely to mobilize for something, and that's just part of the political process. If groups feel that they are going to be harmed in a concentrated way, or they might get very strong benefits from something, they're more likely to mobilize. And so it depends on the topic, depends how it's framed, and it also depends on the processes. If you have a process whereby you're engaging stakeholders, but you have a history of maybe engaging them but not using their information or not really following through on their recommendations, they may not be as engaged. But you might also have a very mobilized group, and so they might feel very empowered to be part of the process. So it really depends on the issue, on the context, and on the processes as to who to engage. I know with the McMaster Health Forum, they have a very set way that they find the stakeholders, they reach out to stakeholders, and they try to engage them through these different processes. So it really, as everything else in this world, it depends.
Great. Thank you so much, Elizabeth. And I'm not seeing any more questions from the chat or the Q&A come through. So if you do have any other questions or chats, we have a few moments for those. We can take those for sure. And just want to invite everyone to join us for our next webinar within the Spotlight series. And we will have a webinar on a tool for sharing best practices from the INFO project within the United States Agency for International Development. They've developed a method for sharing best practices within organizations, and we'd hope that you join us if this is of interest to you to learn more about how you could apply this method within your regional health authority or local health department or unit. So with that, again, I'm just checking to make sure we haven't had any additional questions or thoughts or comments come through, and we do not. Again, if you need to reach us at the National Collaborating Center for Methods and Tools, you can reach us at nccmt@mcmaster.ca, and we encourage you to, if you'd like to log on to our website and explore our resources. And again, we've just posted a note within the chat that the resources from today, the PowerPoint and the audio recording, will be available on our SlideShare, and YouTube accounts. And we would, sorry, and someone's just asked when the next webinar is, and so it is on March 30th from the same time, 1 to 2:30 p.m. Eastern Standard Time. So thank you for that question. And before we end today with no further questions or comments, Elizabeth, I'll just turn it over to you for the last word. Any last minute or lasting thoughts that you'd like to leave with our participants today?
Great. No, I just thank everybody for attending the webinar. I'm very excited about the workbook and the potential, uses of it. So if you do have any questions, please feel free to reach out to me. Please also fill out the survey. It helps me know, how I can present this better and be more understandable for others. So, no, just thank you very much for attending today.
Great, thank you so much. And so for everyone that's on the line, we'll go ahead and sign off for today. Again, thank you so much for being with us, and we hope that we might have you join in